Hello, I'm Paul Walker, medical oncologist with Circulogene. I would like to welcome you and present another case in our Circulogene molecular tumor board series. This is a 53-year-old male, very symptomatic from his bulky right upper lobe tumor. The bronchoscopy pathology revealed a few rhabdoid appearing viable malignant cells, but there was underlying extensive necrosis, which obviated any successful IHC staining and classification. This left the pathologist with a differential diagnosis of was this a primary thoracic sarcoma or was it a carcinoma? And the tumor board discussion then stepped to whether there should be a repeat biopsy for additional tissue for testing or sending the pathology out to a sarcoma pathology expert. Either of those approaches was going to take several weeks at best, and this patient was very symptomatic today and needed treatment as quickly as feasible. Fortunately, there was a liquid biopsy drawn at the time of the bronchoscopy and was available at the tumor board. The plasma next generation sequencing was very revealing, with 7 ctDNA alterations compatible with the aggressive tumor biology, a variety of mutations including STK11, P53, and POLE. The plasma cell-free RNA PD-L1 was highly expressed at greater than 50%, but most notably and important, there's a SMARCA4 mutation. It was first reported in 2015, but now SMARCA4 mutated, SMARCA4 deficient thoracic tumors are a recognized subset of non-small cell lung cancer. The SMARCA4 gene is part of the switch sucrose non-fermenting SWI/SNF complex, which plays a role in chromatin remodeling, DNA repair, and transcription. It can be in a variety of solid tumors, although most frequently in non-small cell lung cancer. It can be also in rare syndromes such as small cell carcinomas, ovary hypercalcemic type. In non-small cell lung cancer, 20% of the time, there will be an SWI/SNF complex mutation. A third of those will be SMARCA4 mutations, which leaves SMARCA4 mutated lung cancer at 7% of non-small cell cases. There are two morphology pathways of SMARCA4 mutated thoracic tumors. When there's the SMARCA4 loss alone, that will have the non-small cell morphology appearance. However, when there is a second hit of the SMARCA2 loss, then that's when it will become undifferentiated small round cell rhabdoid appearing sarcoma morphology. Irrespective of the morphology, the SMARCA4 deficient thoracic tumors are carcinomas and not primary sarcomas. The clinical presentations will be a little bit different. When there is a SMARCA4 mutated lung cancer, it tends to be a little more frequent in males. It tends to be a little younger population. Invariably, there's bulky disease and a high tumor mutation burden. There's also a very high frequency of STK11 and KEAP1 mutations. Normally, this would be at the 15% range. However, in the SMARCA4 enriched population, it can be as high as 50%. Histologically, there can be focal expression of TTF1 and P40, and in a quarter of patients, there will be extensive crush artifact and a high Ki67 of 70% or greater, and with positive synaptophysin, it will mimic small cell lung cancer. The treatment approach is being better defined since it is now a recognized non-small cell lung cancer. SMARCA4 mutated cancers will have a very poor prognosis, but they can respond to immune checkpoint inhibitors. There also may be a preferential benefit of cisplatin chemotherapy-based therapy and not carboplatin. This is just looking in the adjuvant setting of resected SMARCA4 mutations. When they received cisplatin-based adjuvant chemotherapy, they did really remarkably well. The co-mutations do matter. If there's a SMARCA4 mutation alone and there's immune checkpoint inhibitor-based therapy, those patients will do very well. But if there's an associated co-mutation of an STK11 and KEAP1, they do much poorer. What about this patient? The plasma next generation sequencing was very helpful. Although there was not anything directly targetable, the findings were very actionable in guiding the treatment approach. The STK11 with a KRAS mutation tends to be very immune resistant. However, an STK11 with P53 can be immune responsive given the STING pathway activation. A POLE mutation can be very immune responsive. Certainly the plasma PD-L1 expression predicts for an immune benefit. So that really guided the therapy to step 2, a combined cisplatin-based chemotherapy, combination immune checkpoint inhibitor therapy. I think this case really also emphasizes and illustrates the benefit of having the plasma next generation sequencing back as quickly as possible, such that when you are having a treatment discussion and making a decision, you have that information. Clearly, in this case, the plasma NGS was vital in directing the treatment to the cisplatin chemo IO approach, but it also was critical to making the diagnosis. With the SMARCA4 mutation being identified, this clearly confirmed the diagnosis that this was a SMARCA4 non-small cell lung cancer, irrespective of the morphology, and a rebiopsy did not need to be undertaken, and the pathology did not need to be sent out, and the patient was able to start therapy the very next day. As we are in the precision era of oncology, it is vital to know and treat the tumor biology and not just guide our treatment on the histology and anatomical label. Thank you very much.